Dr. Angelo Franzini of Besta Hospital will relate to us about a very interesting topic, especially in the light of their experience, which is one of the leading ones at a worldwide level concerning the treatment of CSF hypertension. I would like to thank Dr. Valentini for giving me the opportunity to talk about this disorder, which has only one thing in common with Chiari malformation, tonsil descent. The group that works at Besta, whose members are listed here, has a passion for this disease and has produced some very original theories which still need to be validated and which I will illustrate to you in a few minutes. The CSF hypertension syndrome was clinically described by Schaltenbrand. He described a severe and worsening headache that is only focused at a given site and that disappears when the patient lies down. This is how Schaltenbrand described it. Subsequently, other symptoms were described. Schaltenbrand interpreted it as the opposite of hydrocephalon. Hydrocephalon is increased CSF, hypertension is decreased CSF. Other symptoms are dizziness, tinnitus, neck stiffness, but also tremor and extrapyramidal signs, as well as focal neurological signs, mainly due to the forming of intradural hematomas. All of these symptoms have recently been compounded by, or to all these symptoms, recently behavior disorders have been added, such as depression and obsessive-compulsive-like syndromes. After Schaltenbrand's clinical observations in the MRI age, neuroradiological features were defined that enable us to formulate a certain diagnosis. The key sign is an increase in size and contrast uptake in the meninges. This sign was observed by us in patients with suspected hemorrhagic pachymeningitis. This is an impressive picture, but the only symptom may be orthostatic headache. What is this disorder due to? As Schaltenbrand guessed, it's the opposite of hydrocephalus. Decreased CSF amounts lead to a series of imbalances down to brain collapse and subdural hematomas. This was attributed to traction on dural structures and bridge and veins, but in fact it is not so. Most experts believe that spontaneous dural tear causes this disorder, but as you will see, we do not agree. Other radiological findings, in addition to descended tonsils and uptake of contrast medium in the dura, is CSF accumulations anteriorly to the brainstem. This is a patient who came to our observation with a diagnosis of epidural abscess and was then treated for CSF hypertension because he had other signs, and he was cured very quickly. We also use isotopic cysternography, or we also inject contrast medium and try to locate escape point so as to figure out where the leak occurs and what is causing the disease. This is something we used to do in the past, but now the concept of looking for a CSF escape point is obsolete, and we will see why shortly. As we said, another symptom is tonsillar descent and of the entire brain stem. This is called brain stem sagging. There's also uptake of contrast medium at the hypophysis level and clivus, and there are anterior CSF collections. Another sign is epidural hematoma. subdural hematoma. This is often the only symptom patients report when they come to hospital. They undergo a CT scan and they're operated on to remove their hematoma, and sometimes the consequences are catastrophic. This is a hematoma, and as you can see at its initial stage, this looks like an intradural hematoma. The dura seems to have divided into two leaflets, and there seems to be blood in the middle, sandwiched between these two leaflets. So these hematomas used to be regarded as intradural hematomas. Sometimes hematomas are bilateral and communicating, and there is also intradural blood in the facies. This has given further substance to our theory that CSF hypertension is not due to chronic intradural hematoma, but rather to a subdural hematoma. This has been confirmed by anatomopathological findings. Around a decade ago, we used to look for leak sites and used to close those sites by injecting a blood patch. But then we found out that all these patients had an extremely negative lumbar CSF pressure. We first realized when, after a lumbar puncture, and since we hadn't been able to administer a blood patch to the patient, we made a CT scan and realized that he had aspirated a big amount of air, whereas nobody had injected any air. So we identified a negative pressure in the subdural space, which we attributed to the venous system. The inferior vena cava has a flow from downstream to upstream, and these are the epidural veins that surgeons see when they operate on the spine. These veins pump blood to the heart by means of a one-way pumping system. So blood is prevented from reaching the epidural system. Void is created, and this void sucks CSF out of the dura. This is our theory. Therefore, we no longer look for leak sites, but rather we create a compression at a lumbar epidural level by injecting a mixture of blood, fibrin and fibrin glue, as well as contrast medium, and therefore we separate the drainage system of the vena cava, superior vena cava, and the inferior vena cava, thus reducing this negative pressure. Sometimes in our patients, usually, there is a remission and the situation is solved. These are the veins that lead blood from away from the circle, and this is the substance blocking communication between these two systems. So blood patch disconnects the communication between these two systems, and the venous blood outflow that's caused by being erect, of walking, and all other activities that cause pumping from the heart. Well, all this is eliminated. In all our patients, which are now more than 100, we have made measurements using water-based systems, and in all patients there is a very powerful aspiration of 20 to 30 cc's of water from within the epidural space. Then we inject 10 cc's of blood, fibrin glue, and contrast medium. We perform a compression. As you see here, it's a very focal compression. In other words, blood doesn't close holes further up. It's a very local compression. This patient had a well-documented CSF leak at T11, and this block led to a closure of the leak. In other words, those CSF leaks that we see are not due to the aspiration, but rather to the sucking up action. This is an effective compression. On the right, there is a typical compression with no compression effect. The one on the left is effective, the one on the right is not effective at solving the problem. In using this approach, we have treated 60 patients whose follow-up lasted until 2008. 11 patients had symptomatic hematomas and 16 had descended tonsils. These are the early cases in which the previous cases where we used to go and look for the leak site, which we then discontinued. Let's get back to subdural hematomas. This is a very old picture from a general pathology textbook by Professor Gallone, who used to teach at the University of Milan, and who used to say that all subdural hematomas were in fact intradural hematomas due to the forming of blood at the intermediate dural layer, which is a highly vascularized layer. Nobody took him seriously, and these pictures were not acknowledged. This is the dura that adheres to the periosteum, and following traction, the hyperemia occurs. This state used to be called hemorrhagic pachymeningitis. So Professor Gallone described this hemorrhagic pachymeningitis as the early stage of subdural hematoma. This is the hyperemic inflammatory state of the dura inflammation. This is Professor Garrone and his treatise where he expounded these concepts. But then, after we developed this idea, we stopped operating on these hematomas, because in 90% of cases, these hematomas heal after blood patch without requiring traditional draining surgery. Those who are not operated on like this may suffer from a coma or other problems such as brain stem crisis. This is a patient with a hematoma. These artifacts are due to the fact that this patient was admitted to our hospital due to a suspect Parkinson's disease. He had also other extrapyramidal signs, but after blood patch, his tremor disappeared, his Parkinson's symptoms disappeared, and the hematoma was reabsorbed. Of course, months are required for all signs to disappear from the meninges, but his tremor and signs disappeared immediately. This is another patient with hematoma who, a few weeks after blood patch, showed that his hematoma had completely disappeared without a need to resort to surgery. So, according to our theory, one shouldn't look for the CSF leak site, but rather try and correct the venous and epidural pressure imbalance. In order to be confirmed, this theory requires measurement of pressure between the superior and inferior vena cava in the heart, but this is not technically possible. Therefore, this theory is only based on the evidence that this treatment leads to recovery, and this has been demonstrated in, by now, nearly 100 patients. Thank you. I have a short question. There are 3 or 4 questions lining up, but it's lunchtime, so I have a question. Of all these 60 patients, did you notice whether the incidence of spinal canal stenosis was very low? Do they have a normal spinal canal? Yes, they do. What they have in common is that they are tall, slender people who walk a lot and who run a lot. This is what they have in common, but there are also some elderly patients included. Thank you, Dr. Franzini. Your contribution was extremely interesting because it attracted our attention on a concept that's not very well considered. That is that the lower part, the sac, allows for compliance. Sometimes we see opposing pathologies which are due to fibrosis or tumors. Not infrequently, lumbosacral tumors cause hypertension. In this case, it is due to the fact that the system has a very low compliance, whereas with hypertension, compliance is extremely high. You said it was difficult to make pressure studies. Yesterday you were probably not there, but by MRI it's possible to measure compliance of the system. We do that with hypertension, but it's probably possible to do so in a non-invasive manner with hypertension too. So it's a non-invasive way of studying these patients. Surely, and this attracts our attention on the lumbar venous system, which affects the absorption of CSF leaks. Sometimes tumors can cause hydrocephalon as well for the same reason. We have observed 200 patients for 15 years, and we have treated about 50 for hypertension. Your assumption is fascinating, but I have a few perplexities, because sometimes in these patients, this syndrome is also triggered off by maneuvers such as cervical manipulations. And indeed, in those cases, CSF leaks lead to a dural collapse, which in turn causes vasodilation, and notably vein dilation and venous outflow. We put them in a reverse Trendelenburg position for 24 hours, and we have a 60% rate of successful outcomes with just one patch, which is a very much higher rate than others. As for hematomas, we had 107 hematomas with a mass effect that led to intracranial hypertension. 2 of them had never undergone surgery, and they relapsed 2 or 3 times, and then they healed without a blood patch because the diagnosis was made post hoc. In other cases, when possible, we performed a patch treatment, and when it wasn't possible, we drained the hematomas, and before the patient resumed his erect position, we performed a blood patch treatment. To quickly answer your question, I'd like to say that we've also had many cases that were a consequence of failed lumbar puncture. But if there is no negative pressure in the epidural space, there can be no CSF leak, because CSF must go somewhere. It can't possibly disappear in thin air, so it's most certainly absorbed by veins. So once this epidural suction mechanism is tackled, CSF is restored. In our view, the underlying feature of this pathology is venous circle pressure. It's very fascinating. You showed a 3-centimeter hematoma. Why did you decide to perform a blood patch instead of draining it? This is a long story. The first case report stems to 30 years ago. We did it with Professor Broggi. It's a patient who had a hair transplant and he didn't want to be reoperated on. We assumed it might be due to CSF hypertension, so Dr. Broggi gave him a cervical blood patch because the patient sneezed and that caused him a headache. The hematoma has disappeared. This was a man an anchor man, so everybody told him he had to be urgently operated on. He was cured with a puncture, and ever since all hematomas have been treated like that. When are we going to resume our proceedings after lunch? 2:45. Okay. Enjoy your lunch and congratulations.